Everybody notice, even I will agree that I have a hoarseness. Your mind is tuned to homeopathic thinking. Each one of you has already thought of a remedy for me. You know how I learned this? When I first met Saralaben and Vishpala, Saralaben looked at Vishpala and said, "Healthcare ka chip." 10 years later, just before she passed away, she said, I want to introduce you today to clinical thinking. The time that we spend, can I have my PPT please? The time that we spend when we see the patient first and we start asking questions, we should have clinical possibilities coming in our mind in addition to your homeopathic possibilities. So your job is double. So if you thought hoarseness, clinical thinking will say most likely laryngitis. Let me ask, acute or chronic? If it is chronic and recurrent, maybe he is a teacher, vocal cord nodules. If it's very chronic, not recurrent, and he is a smoker, maybe malignancy. So our thoughts have to be trained now, because today the times are difficult. We are bound by law. You can say that I decided this remedy was fine, and you can prove that lateral movie was fine, but then it didn't work. And then you can't miss clinical. Even Amitabh Bachchan said, 20 दिन हो गया तो एक्सरे करा लो. You cannot say 1 महीना हो गया तो मुझे नहीं लगा टीबी होगा. No, sorry. So I think it's time that those of you who are already practicing and those who are new develop some clinical thinking, and I will take it forward with perspective to heading. What is clinical thinking? Self-directed. It is directed at me. Self-discipline. I control it. I don't want it to go haywire. Headache, patient first visit, lipid profile, kidney profile, X-ray, CT scan. No. Self-monitored. I decide 4 possibilities. I rule out 1, then I have 3, then I have 2, then I have 1. And self-correcting. Your first thought may be anything, but the best physician is the one who does not hesitate in correcting himself or herself. Because who knows? I only know. Na? My first thought was wrong. It entails effective communication and problem solving ability. So your ability to ask the THE capital right question and solve the problem patient faces, and a commitment to overcome our egocentrism. We doctors have a tremendous ego. Knowledge 2 पैसे का नहीं होगा, लेकिन 56 इंच का छाती से. Clinical thinking is influenced by your knowledge. You need knowledge, sir, otherwise you can't think. Your experience. Using strategies such as reflective thinking. Always admit your failures, because your failures teach you the most. As a part of learning to identify the issues the patient has, the opportunities, because you are homeopath, even as a allopath, I have to holistically synthesize the information coming. I have a patient coming to me with chest pain. and I know it is gastroesophageal reflux. I'm not thinking only of chest. Coming to headache. Most common form of pain reported during visits and major reason cited for missed work or missed school. And this I will tell you, in India, no one does. Even people who call themselves headache specialists don't do. But we should have a diary. Because there are patients, मैंने अरे भी headache था ना, एटलू था कि only I can tolerate. It may be on a scale of 2. But did you miss school? No. Did you miss work? No. You should have a diary of how much work was missed. Doctor, I had so much headache, I didn't go for a wedding. Yes, that is significant for me. Without proper treatment, headache can be severe and interfere with daily activities. Nowadays, most patients will come and tell you, headache hatu, dolo le li. So that is maybe the cause of headache. I'll tell you as we go ahead. Certain types of headache runs in families. They actually are familial headaches, but many times the mother whole day keeps saying, she'll tell the child to dabao sir. The child, due to love, starts getting headache. Episodes of headache may ease or even disappear for a time and recur later in life. I had headache when I was 18, then nothing. Now at 40 I started. And it's possible to have more than one type of headache. Same patient can have migraine, tension type of headache and cluster headache. How do we approach? Ideal way is to first divide, is it a primary headache, is it a secondary headache? Because primary headache, like primary hypertension, I treat headache. Secondary headache, I find out what is causing the headache. X-ray and blood test does not help headache. So if you are asking a patient to get CT, be sure what you suspect, because patient will say, I spent 5,000. What did you suspect? The diagnosis is identifying the pattern. A good history is an invaluable tool. There is the headache. I am sure homeopathy has more questions. When does it occur? What type of the headache? Aggravating factors, relieving factors, associated features, relation to menstruation, other physiological events, and loss of school days and lack of work days. Very important question. We have to differentiate very easily between primary and secondary, but between primary it's difficult because people may have multiple primary headaches. Right question, right manner, right order. Headache patients are in pain, are often depressed and sometimes frustrated because they have not been able to get relief from other doctors. So all the questions you may ask, they may think are repetitive. Be very clear what you want, because each question should lead you to the next question and not otherwise. I remember some 15-16 years back, working with Dr. Vishpala's assistant, Dr. Sushma Jaiswal here, we had created a massive questionnaire of headache to run a headache clinic in her dispensary. So we need to establish rapport. Patient may have come to you after having failed 10 times, but he should not think कि चलो इनको भी try कर लेते हैं. That rapport should come. वो okay, I think I have come to the right place and I am going to get better. And then there is no set question, there is no template. We need to improvise as we go along, based on the information that we have obtained, and has to be done in the right sequence. If you have taken a very good history, then based on the timeline and associated features, you should have a provisional working diagnosis even before we examine the patient or plan any investigation. Now imagine if I have a patient come to me, think fine. I have been under treatment by Dr. So and so, who's a headache specialist in a tertiary care hospital, last 7 years for migraine. The headaches are not going. I would not even look at the file because I know now the diagnosis is wrong. I will only look at the file to look when I am starting to prescribe. Then you have to ask your own questions, your own order. You will see it's very easy in headache. Migraine is a waste paper basket diagnosis. कहीं नहीं समझे तो migraine. And in psychology, schizophrenia is a very waste paper basket diagnosis. कहीं नहीं समझे तो schizo नहीं हो तो schizoid लागे छे. So please beware, don't fall in that trap. So classification. Secondary headache, like secondary hypertension, is caused by an underlying structural, chemical or other etiology. Primary headache is a disease by themselves. Primary headache is migraine, tension type headache and cluster headache. Secondary headache I have written in red, which you cannot miss: meningitis, subarachnoid hemorrhage, intracerebral hemorrhage. Then fasting, hyperacidity. Many of my patients bless me because I have saved them from headaches and spending money. After first consultation and diagnosis, I know it's acidity. They'll call me, doctor, severe headache. I take some history. I said, take a big cup of vanilla ice cream. They don't even have to come. So they save money every time they have a headache and they know it's empty stomach. They take ice cream. Ocular headache. For every headache patient, ask, do you have glasses? Yes. Where are they? At home. I only use them for reading. Are they reading glasses? Are they bifocal? Bifocal, they'll understand. If they are not bifocal, then ask, are they progressive? They don't know. Did you spend more than 10,000? Yes. Then they are progressive. You need to wear full time. Because you need to ask, and you cannot treat a headache patient if the patient is not correcting the ocular problem. Sinusitis headache. Very, very common. Tumor. A child coming with a headache is either identifying with mother or has meningitis or has a tumor, nothing else. A child coming with giddiness, with nystagmus, has tumor, nothing else. You should have that kind of confidence in your knowledge. And temporal headaches only, giant cell arteritis, you can actually feel the artery under your finger. What is primary headache? A chronic, benign, recurring headache. Benign means it's not going to kill the patient. without known cause. So a patient says, no, why am I getting migraine? Don't even start asking. Nobody knows. It's a cascade of events. Primary headaches are due to affection of blood vessels and nerves inside and outside the head, causing pain. Migraine, cluster and tension type headaches are what we will discuss today because they are the most common. New headache. So first question to a headache patient is, it's a new headache. A headache of recent onset or a chronic headache that has changed in character. Such headaches are more likely to be pathological or secondary rather than primary. And you need to have good credibility in the market for a patient to come to you for first headache. So how do we evaluate a headache? Patient has headache. Are there warning signs present? We'll tell you what are the warning signs. No. Yes. The present yes. Yes is secondary headache. No is primary headache. Secondary headache, investigate. Don't say I will try this for a week and see. You may not see the patient ever. Primary headache after treatment, atypical features. Maybe migraine, but it's atypical. Again investigate. Those of you who want to take a picture, I will give you 2 seconds. So what are the warning signals for secondary headache? A headache. I have been getting headaches, but doctor, this headache, my God, I fainted. Versus recurrent headaches. One question for any acute sick condition: severe headache, severe abdomen pain, severe backache. First time, I am anxious. First time, no, I get it often. I am relaxed. Somewhat relaxed because this patient will not die in my cabin. Sudden onset thunderclap. An 18-year-old girl sitting in a gurdwara having langar. Papa! Dead. Thunderclap headache. Papa headache. Vomited. Unconscious. Subarachnoid hemorrhage. Unless proven otherwise. Instantaneously with maximum intensity. New onset of headache after 50 years. Patient at 50 year plus. New onset, secondary. Systemic sign. Headache, fever, myalgia, weight loss, something sinister. Known case of malignancy, known case of HIV. Any malignancy, મારી malignancy cure થઈ ગઈ છે. Recurrent headaches, consider meningeal spread. Changes in headache pattern. Progressive headache with, initially doctor I used to get 3 times a year, but now I am getting every month, and last 3 months every 15 days, reducing period between 2 episodes. Changes in headache severity. Initially I could work, but now I can't work. And cognitive changes, higher function changes, loss of memory, loss of concentration, and asymmetry. Headache on one side, other side, changing sides. Coming to migraine, most common disabling primary headache, most common in your practice, For patient who's bouncing back from somewhere will never come with cluster headache under treatment for migraine. That patient I told you, 7 years under treatment, that lady was taking painkillers every day for 7 years, twice a day, and still she had pain, and the doctor did not bother to think that it's not migraine. Most widely recognized, patients will also tell you. So my practice, my experience of 45 years says, if a patient comes and says, I have migraine, I think it is not. Because if it was migraine, what are you doing in my clinic? You should be better. It's like when a patient comes and says, I have chest pain, it's more likely to be I have hyperacidity. I have severe acidity in the midline, cardiac. There is a textbook of medicine, Cecil. In the foreword it's written, isn't it ironic that graveyard is full of people who died of gastro? All your relatives, all your friends, you have one case at least. गईकाले राते तो सरस आता, थोड़ी चेस्ट पे तई सोडा लीधु पण didn't get up. Adults, recurrent attacks lasting for 4 to 72 hours. So migraine can last for 72 hours, 3 full days. And above 72 hours, it becomes status migrainosus. In children, goes early, but up to 3 days it can last. So what are the commonly used terms? You will see now, migraine is not a headache, it's a syndrome. Aura. Complex neurological phenomena that precede a headache. Scotoma, seeing dark spots in front of your vision. Aphasia, difficulty to talk. One side weakness. Photophobia, classical for migraine, worsening of headache on looking into the bright light. Phonophobia, pain worsening on loud noise. So migraine patients will always, you ask, do you feel better if you are lying down in a dark room with no noise? Yes, I feel better. Migraine is not just a headache. You have pre-headache prodrome, then there is aura, then there is headache phase, which is divided between mild, moderate, severe. Then is the rescue period when the severity starts coming down, and then there is a post-headache, post-drop. It's like after a convulsion there is a post-ictal phase. People take time to become normal. Aura is a complex of neurological symptoms that occur just before or at the onset of migraine. Most patients have headaches without aura. It's not that if you don't have aura, you don't have migraine. Only 15% experience aura. Aura may occur without headache. Some people may have aura. If treated well, they may not get a headache. A typical aura lasts 5 to 60 minutes and may occur before, during or after headache. Treatment at this phase may prevent the development of pain phase of the headache. If you identify or if you diagnose your patient well, you can give acute medicine. When you start aura, take this medicine. Pain may never come. You have to differentiate aura with transient ischemic attack. Migraine aura, positive visual symptom. I see black spots, I see flashing spots, and TI has negative visual symptoms. I cannot see. Big difference. Migraine aura, gradual onset, TI is sudden. Aura is more than 20 minutes, TI is less than 15 minutes. In migraine, headache follows in 50%, Headache is very uncommon in TIA. Migraine aura, identical repetitive attacks, flurry of attacks midlife. Those of you who are subscribers of NGH, this will be published in the NGH issue. So need not take notes, others can take. No, I should help them out. Or I am not saying subscribe. Pain phase. Now the headache begins, and that is the trouble. A patient who can function with the headache of migraine is mostly not. Doctor, I had party of 10 people at home and I got headache that morning. Could you cook? Yes. 6 dishes I made. Migraine nahi. Because then she will cancel, she will order from out, she will do something else. Patient wants to rest quietly. No sound, no light. Pain of migraine usually begins above eyes. Typically affects one side of the head, but not always the same side. Tends to feel throbbing. How we feel our pulse, patient will feel throbbing there. May throb worse during physical activity. Other symptoms, already we have said photophobia, phonophobia, unusual sensitivity, headache may be light, patient may feel fainting and nausea, vomiting. Most migraine should have vomiting and vomiting relieves the headache. I have migraine for 5 years. How often have you vomited? Not even once. They are proud. Now I know it's not migraine. During mild to moderate phase, medication is most effective. So all your migraine patients should have a medicine with them rather than saying aake le lo. No. Severe pain phase, medication will not work. So if you are promising, no. You take in aura, maybe result in 10 minutes. Take in mild phase, result in 20-30 minutes. Severe pain, half an hour, 1 hour. Don't promise sky. What are the risk factors of migraine? Menstruation, sunlight. The risk factors can be minimized because all medicine, allopathy, homeopathy, require lifestyle management. Proper diet, 7 hours sleep, meditation, relaxation, stress management. Characteristic features of migraine: frequent temporal association with menstrual cycle. Period na first day headache chalu the. And then we know there is a relation because migraine is throbbing arteries. Periods are throbbing of arteries in the uterus. Triggers can be red wine if people consume. Paradoxical relation to sleep. Attack frequently occur during sleep or upon awakening. And after COVID, another headache has come upon awakening, which I'll tell you towards the end. But migraine also relieved by sleep. Family history of migraine in 80%. Reversible attacks with cognitive impairment, forgetfulness, concentration lost will all be there. And sometimes dizziness, vertigo. All of us should learn how to check nystagmus because that will tell you this is vertigo as per patient or this is true vertigo. So classical migraine with aura, common migraine without aura, menstrual migraine, silent migraine, aura comes, no headache. Vestibular migraine, no headache but giddiness, vertigo. Abdominal migraine comes in children. Hemiplegic migraine, when the migraine occurs, person gets hemiparesis, totally recoverable. Ocular or retinal migraine, they lose sight for some time when the headache occurs. Migraine with brainstem aura, palpitations, fainting, tachypnea, status migrainosus lasting for more than 72 hours requires ICU hospitalization. We do not try to treat in the clinic. Without aura, there is a way to classify at least 5 attacks fulfilling criteria B and D. B is headache lasting 4 to 72 hours. C, headache has more than 2 of the following characteristics: unilateral location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity, nausea, vomiting, photophobia, phonophobia. Out of this, 2-3 should be present. This we already discussed. Sorry, I have consumed my time. So I have discussed most of this. I am just running through slides now. So if you diagnose menstrual migraine, you can start the treatment a day or two prior to period beginning, if the periods are regular. Vestibular, as I told you, giddiness, balance, no headache. Abdominal in children, like there is abdominal epilepsy, there is abdominal migraine. It generally goes away with growing age, but many of them will get back in adulthood. Again, as I said, attacks of blindness or visual problems which are temporary, non-pharmacological management, maintain a headache. If you start this now, that will at least differentiate you from other practitioners. So, tell the patient, the day of the headache you write, head headache, scale of 0 to 5, what was the scale? According to you, what was the cause? And that diary, patient, patient, if you ask him no, on follow-up, how are you? हेडेक हुआ क्या? नहीं, वैसे तो हेडेक नहीं हुआ, but I am feeling weak. This diary will be an evidence. Boss, you are better. Avoid overuse of OTC drugs. Even these Dolo, Calpol should not be taken. Strive to maintain normal weight. 30 minutes a day to reduce stress, because stress is the trigger. Try to wake up same time each morning. Today, young people, I am sorry to say all of you are young, are dysfunctional. They cannot sleep till 2 o'clock, 3 o'clock. कितना भी deep sleep होगा ना तो एक WhatsApp notification आया तो, and then forward that time only. 30-minute exercise every day. Reduce tea, coffee, and reduce artificial sweetness. At least 7 to 8 glasses of water. Coming to second, cluster headache. One-sided excruciating pain with watering of the eye, with redness of the eye, is a cluster headache. I will summarize it how to differentiate between the team. Often occur at night. Acute treatment is control the severity of headache as well as the duration of the pain. Both should be better, both should be targeted. There is no cure. Homeopaths love the word cure. હું તમને ક્યોર કર્યું. No cure. Goal of treatment to decrease the severity of pain. And a patient will ask you, sir, guarantee છે ને? No guarantee. Treatment of acute headache, if patient is severely in pain, taking oxygen for 10-15 minutes helps. Tension type headache, muscle tension. Tension type headache is actually a muscular pain because our head is 4 to 6 kilos. It is held straight by these muscles. So when these muscles are irritated, now they give a headache. Mostly people don't come to you because it goes with OTC medicines. And sinus headache, very classical. Examine the patient's nose. Inferior turbinates will be swollen, and press on the supraorbital nerve. Is it paining? Ouch! Sinus headache. For all you know, this patient is treated for migraine also. Treat sinusitis. Sinus headache will also get worse in the evening. So ask the patient, जितना दर्द सुबह होता है दोपहर में बढ़ता है, शाम को और बढ़ता है, आपको कैसे मालूम? Because sinuses contain air. As the day progresses, temperature goes up, air expands. So if the sinus wall is congested, the headache will worsen. Medication overuse headache. This is actually a clinical entity. Taking too much of painkillers causes headache. Ask the patient that you to stop all this habit. Pain medication for arthritis don't cause headache. Cervicogenic headache, headache due to the cervical muscles. So I found a new class of headache after COVID. People were at home, nothing to do. Everybody had to do housework, so daytime no time for mobile. So they will lie down in the night and doctor, itna severe pain in the I can't tell you. So I started asking one question. Do you use mobile in bed? Yes. Stop. And if you examine, no, these muscles are like steel wires. This is cervicogenic headache. So to differentiate, this is migraine, this is sinusitis, this is tension headache, and this is cluster headache. And one important thing for all practitioners, when you are having a headache patient in your clinic, before you send the patient back, ask yourself this question: can this patient die now or within 24 hours? All headache, especially in children, and acute headache should be checked for meningeal irritation, neck stiffness, Wernicke sign. All headache with vomiting are not migraine, they could be meningitis. Sudden thunderclap headache. Please, when you're talking of acute headache, don't be sharp. Think this. This question I ask every patient. In my mind, I ask fever patient, ये मरेगा क्या आज? When I'm sure नहीं, then I say वो. So just to publicize myself, I conduct free webinars every Thursday on clinical medicine. Those of you who want to register, write down this number मच.